Hello everybody, welcome back to my channel. I am back with an interesting topic. We're going to talk about digoxin fact. I know all of you guys already know what is digoxin and what it does, but I don't know if anybody has ever wondered how come a drug used to decrease the heart rate in atrial fibrillation is also used in heart failure when the heart is unable to pump. So I always wonder, even in my nursing school study about this medicine, and I finally understand the deepest of the mechanism of action of digoxin, which explains everything. And this is the purpose of this video, to make it sweet and easy to swallow for you guys. So I have a framework here. We're gonna start talking about digoxin mechanism of action, and then the indication, special consideration, toxicity, and interaction. Please stay tuned because it's gonna be so interesting. Now, before we start talking about the mechanism of action, we need to know the basic at the cellular level. So let's talk about the cell, right? So in our cells, we have ions. Some ions are mainly inside the cell and other ions are outside the cell. So if I have a cell here, normally outside the cell I have more sodium, and inside the cell I have more potassium, right? So my sodium is going to be here, more so outside of the cell, and inside the cell I have more potassium. So normally it says that we should have, because we have sodium more outside the cell, normally the sodium was supposed to go inside the cell to make it balance. But it happens that we have this pump that pushes the ion against their gradient of concentration, and it is called the ATPase pump. And because it pushes them against their gradient of concentration, it uses a lot of energy. So it's a pump that uses energy. So what is this pump going to do? This pump is going to make sure that more sodium goes out, even though the sodium is already out. So it's going to push 3 sodium out for 2 potassium in. So, and this is what that pump, ATPase pump, is going to do. So 3 sodium out, 2 potassium in. And this sodium going out, it is going inside another cell, right? So that sodium diffuses in here to go inside the cell. Now, inside the cell, the sodium is exchanged with the calcium. So when the sodium goes inside here, the calcium go out. So when the sodium goes in, the calcium go outside the cell. Now, what makes a muscle to contract? So here, remember, inside our cell, we have the sarcoplasmic reticulum. Here, sarcoplasmic reticulum is an organelle inside the cell that releases the calcium here inside the cell. And when that calcium gets to a level, it helps with the muscle contractility. Now, let's talk about the direct mechanism of digoxin, the direct mechanism of action of digoxin, now that we understand this basis. So digoxin is going to come to this pump, bind to the pump, and inhibit the exit of sodium. Digoxin don't want the sodium out. So it's going to bind on the ATP pump, and the sodium is not going to go out. And if the sodium don't go out, it does not go inside this cell. And the calcium is not able to go out. It's like a chain of reaction. If I'm not out here, I'm not in here. So I'm not getting this exchange. So what is going to happen if we don't get this calcium out, the calcium stays inside the cell. And because the calcium stays inside the cell, that's what gives us our muscle contraction. The increase of calcium inside the cell. Now, and this is why we say digoxin is inotropic positive, because inside the cardiac cell, it's going to help this calcium accumulate inside and give us a force of contraction. So this is inotropic positive. And this is the reason why we use digoxin in heart failure, because our heart is unable to pump that much blood, and digoxin, through this mechanism, increase the calcium inside the cell and give us that force of contraction, helping when the heart is unable to pump enough. Now, notice that this action has nothing to do with the heart rate. It's just that force of contraction through the accumulation of calcium inside the cell. And this is the direct mechanism of digoxin. Now let's look at the indirect mechanism of digoxin. So digoxin indirectly is gonna activate the parasympathetic nervous system. So digoxin here is gonna activate the parasympathetic nervous system. And remember, our parasympathetic nervous system is the easy system that helps us relax, keep us alive. It's very smooth. So because it activates the parasympathetic nervous system, it's going to activate the muscarinic receptor in the heart. These are the receptors where acetylcholine bind for the postganglionic nerve in the parasympathetic nervous system. So when it activates these receptors, the parasympathetic mostly work on the conduction of the action potential in the heart. So it's going to slow the rate of the AV node. So it's going to slow the rate on the AV node, and we're going to have a decrease in heart rate. And this is how digoxin gives slow our heart rate. So digoxin is going to be inotropic positive and chronotropic negative, because it slows the heart rate. So this is how we have this dual effect in the same drug, which is amazing, right? And this indirect action helps give the indication of digoxin in case of atrial fibrillation with rapid ventricular response. So we're going to give this in AFib with rapid ventricular response. With rapid ventricular response, because it slows the conduction here. Remember, the parasympathetic mostly act on the conduction system of the heart, slowing the heart rate. And that's why we give it in AFib with rapid ventricular response. So now that we have the direct and indirect action, if we sum both of these actions, so we have a heart that pumps great, and also we have a parasympathetic that is activated, relaxing all these blood vessels. So we're going to have an improve in our circulation. So that's why when we give digoxin to patients, we have an increase in diuresis because the renal is having more blood coming in, because the cardiac output has improved and the parasympathetic nervous system is activated. So that's why we're going to have diuresis in people taking digoxin, because their renal function is improved. So we just covered the mechanism of action and the indication of digoxin. Now let's talk about the special consideration, potassium. Now, it is a fact that hypokalemia less potassium in the blood, is going to increase the digoxin binding to this pump. So hypokalemia increase the effect of digoxin binding to the ATPase pump. So this is why we say hypokalemia increases the toxicity of digoxin, because if you have less potassium, more digoxin bind to this pump and more muscle contraction. So you don't want to give digoxin to a patient without checking his blood potassium. So you want to make sure that the patient don't have no potassium deficit. And for patient in heart failure taking digoxin, most of the time they take like diuretics, right? They take Lasix that could flush their potassium out, and you can find yourself into hypokalemia. So you want to make sure that your potassium is correct before you give digoxin. Now magnesium is a cofactor of this pump. So in order for the pump to work well, you need magnesium. So if you have hypomagnesemia, your pump is not working well. So you want to make sure that you want to correct any hypomagnesemia, because it's the hypomagnesemia, it's the magnesium that makes sure this pump works well. And calcium, we saw that is the increase of calcium inside the cell that was leading to the muscle contraction. So if you have hypercalcemia, you are increasing your risk of digoxin toxicity. So hypercalcemia is going to increase the muscle contraction. With digoxin, it's just going to increase the risk of arrhythmia inside your heart. Now, I also mentioned hypoxemia. So hypoxemia, what does hypoxemia do? So if you have less O2 into your body system, if you have a decrease of oxygen into your body system, that decrease of oxygen is going to be sensed by the carotid and aortic body. They have baroreceptor. So those baroreceptor in the carotid and aortic bodies are going to sense the decrease in oxygen, and they're going to send the signal to the brain, to the medulla oblongata right down there, which is our center of all the breathing reflexes control that we can, the hemodynamic control, right? And once it sends it to the medulla is going to respond by increasing in your sympathetic nervous system, the catch and flight system. And what that sympathetic nervous system is going to do is going to release the catecholamines, right? It's going to release epi and norepinephrine. And what does this have in common? They have beta-1 receptor activation. They are beta-1 agonists. And because they are beta-1 agonists, they're going to act on the heart and increase the contractility, right? So if you have a situation of hypoxemia and you're giving digoxin, you have double increase in contractility of your heart, and that could give you cardiac arrhythmia. So this is what is important to correct any hypoxemia before you give digoxin. Now, in daily practice, it's not most common, but when you when you are a CRNA and you have a patient taking digoxin for a longer time, and you want to make sure that you don't give him an hypoxic mixture of your gas, because this is what is going to happen: more cardiac arrhythmia. Now, I talk about phenytoin and lidocaine. Lidocaine is an antiarrhythmic, right? A class 1B antiarrhythmic, and phenytoin. So these I give like we give them in the pre-treatment of digoxin because we want to prevent the complication of digoxin. Digoxin is a powerful drug, but it also leads to many arrhythmias in the atrial and in the ventricular. Now, these act mostly on the ventricle. So we give these because we want to prevent the ventricle arrhythmia when we give digoxin, right? So this is why I mentioned these too. Now let's talk about the toxicity. Now, if you have a patient on digoxin, that the early sign of toxicity is going to be GI. You're going to have your patient having nausea, vomiting, abdominal disturbances. These are the early signs. Now, if you have that patient on digoxin and he have this GI symptom, if you draw a blood level of your digoxin sample, if it's less, if your blood level is less than 0.5 nanogram per ml, you can say no, these GI symptoms are not indicative of digoxin toxicity. Now, if you draw the blood sample, it's between 0.5 and 2.5. This is our therapeutic dose. So this is where the patient should be taking digoxin. Now, if that dose is greater than 3 and the patient having those symptoms, my patient is having a digoxin toxicity. So you want to take care of that. And also, talking about the toxicity, the main digoxin is mainly excreted through the kidney. So you want to make sure your patient kidney works, the kidney function. You want to measure your GFR, make sure everything works before you give digoxin. And also on the EKG, you can find some signs that lead to the toxicity. And the mechanism of action also explain you those signs, right? We say digoxin gives arrhythmia, both ventricular and atrial. And also, because it slows the heart rate, you're going to have an increase in your PR interval. So if you have an EKG, you have an increase in your PR or block in the presence of tachyarrhythmia, and the patient is taking digoxin, that's a tell sign too. And most common of digoxin toxicity also are represented by ventricular fibrillation, and it's also the most common cause of death. So you want to also make sure you check your EKG when your patient is getting digoxin. And how do you treat the toxicity of digoxin? You want to make sure that you don't have hypokalemia. You want to give potassium to this patient because we said hypokalemia increase the digoxin binding to this pump, right? You want to make sure that your magnesium is within the normal range, and you want to make sure that your patient is not having hypercalcemia, right? Because it increases the muscle contraction. You can also do like dialysis, and you can also give digoxin antibiotics. Yeah, you can give digoxin antibiotics. So the interactions, mainly like we say, you don't want to give digoxin with your beta 1. You want to be very cautious. Any medicine that have a beta 1 agonist activation is going to lead you to more tachyarrhythmia. Any medicine that is going to increase your calcium, like verapamil, all those calcium channels blocker, they're going to increase your level of digoxin. You want to make sure that your ACE inhibitor, your ARBs, when you give them, you want to make sure your potassium, everything that is going to flush your potassium out, you make sure that your potassium level is within the normal range, not to increase your risk of digoxin toxicity. Now guys, this is what I got for this video. This is not all inclusive, but these are the main points that I thought it was important to know. If you like this video, please click the like button, subscribe and share, and I will see you on my next video. Thank you so much for watching.